test, so hopefully y'all got to chill and relax a little bit. Hopefully. Alright, so I forgot to do our GI quiz. Sorry, last week when we talked, so let's do that real quick and then we'll jump into pancreas. What do you guys think on this first one? You didn't see it already. Alright. Stricture, right? So when somebody has abdominal surgery, we worry about strictures forming. If that stricture forms, you have the potential to have an obstruction. And if we have obstruction, that's when we get that gal, the bowel gas pattern that we may see. So just be careful if you see that. Esophagus, that chronic, typically chronic reflux. We get that metaplasia that can happen. You worry about that metaplasia, dysplasia. Whoa. Whoa. So that's different, right? So we talked about the different kinds of esophageal cancers. The lower ones are typically the adenocarcinomas. The upper ones are squamous cell, typically. Yeah. Let me go back real quick. So can chronic gastritis cause this? Potentially, if that acid's going into the stomach, then yeah. So I can see why you make QD. I wouldn't do that on a test because it's kind of too close, if you will. So, all right. Wow. I like how
Didn't you say it was
but what y'all say? B,
all of them, all the above.
all the above? That's not a question. That's not. Is there an answer?
All right, let's take
Loaded?
it.
Is it? What does I say? So we talked about the acute causes, right? NSAIDs are one of the most common things you're going to see. The H. pylori is typically that chronic gastritis. Tylenol, we don't really associate that with gastritis. Caffeine may cause lower esophageal sphincter relaxation, which may cause GERD, but not gastritis, right? So aspirin, NSAIDs, ibuprofen, naproxen, we worry about that causing that acute gastritis. What y'all think? E? We didn't talk about E, so it's not one of those. Don't say E.
Well, that's obvious. We didn't talk about it. It sounds weird. Oh.
So we didn't really talk about this too much, but something that you guys should be aware of. If somebody has some type of autoimmune disease, they may have more than one thing, right? What are we talking about?
98.
But just worry about when somebody has an autoimmune disease, they may have other autoimmune diseases. That autoimmune gastritis, we worry about that. That's going to cause that anemia, that megaplastic anemia. You may see hypersegmented neutrophils as well with that. stuff.
D.
Yeah, so remember Crohn's is typically that right-sided, right? Typically it can affect that, most of the time it affects that ileum, but it can affect anywhere along the GI tract, the mouth, esophagus, colon, and those scattered, or those skip lesions, that's typically associated with Crohn's. Ulcerative colitis is the other one, it's that left-sided disease. Typically it's kind of spread from the rectum proximally all the way up to, typically the transverse colon. You don't get those skip lesions like you do with Crohn's. Remember that left and right. We all like
B.
you like B? I like B too. So diverticulosis, most people have, or a lot of people can have these. They're typically asymptomatic. You'll find them a lot when you're doing colonoscopy on somebody. But because they have them, we don't really do much for them. We just try to make sure that we try to prevent them if you can by increasing the fluid intake and fiber. But when that thing gets plugged up, they become inflamed, right? You get diverticulitis. So why does this dude have rebound tenderness? He has peritonitis, right? Probably a perforation. So if that peritoneum is inflamed, we push on that abdomen, it's probably going to hurt. And when we let go real quick, it's going to hurt a lot worse. That's a sign of peritonitis and potentially some type of perforation. Last one. So they're all potential differentials, right? Potentially all of these are causing them, but what do we care about? What do you really worry about with this patient? Cancer, right? Old, changing bowel habits, we worry about colon cancer. How are we going to find this? Colonoscopy, right? That's going to give you the best method to detect this thing. You can actually take a piece of it, biopsy too, and kind of see how bad it is, if you will. But yeah, if somebody has, you think, colon cancer, get that colonoscopy and make sure that it is that or it's not. So we can get that patient some care. All right. All right, so last lecture before our test. We're going to talk about the pancreas today. And the pancreas is one of those organs that's super important, but causes a lot of issues. Especially, diabetes is a very common thing you're going to treat in clinic. And then the worst case scenario, you worry about pancreatic cancer, which is very difficult to treat. We'll talk about that more towards the end. So the pancreas, as you guys recall from AP, that thing sits retroperitoneal. It sits behind the peritoneum, right behind the stomach, right? It's the head of that pancreas is next to that common bile duct. And we worry about that common bile duct, especially if it becomes obstructed, potentially causing obstructive jaundice. The tail kind of goes towards the spleen area. And so, if the spleen is causing issues, then maybe that tail link can cause issues as well. Or if there's an issue in the spleen of the pancreas, or the tail of the pancreas, you worry about it causing issues with the spleen. The pancreas has kind of two kind of primary mechanisms of action, right? Its main job, or one of the main jobs, is to help digest things that we eat, right? So it has an exocrine function. It secretes enzymes that help us break down certain things that we eat. So amylase helps us break down carbs. Lipase helps us break down fats, right? And then proteases, different kinds of proteases that the pancreas has. We won't get into specifics of those, but they help us break down proteins. That's the exocrine function. The endocrine, that's more involved with managing our blood sugar, right? So glucagon, that helps us bring up our blood sugar, especially if we're in a fasting state. Those are made by the alpha cells. The beta cells make insulin. That helps bring down our blood sugar, especially after we eat. We need that to kick in, that we can get that blood sugar into the cell, that we can start making energy. And then the delta cells, they produce something called somatostatin, and that kind of keeps the brakes on both glucagon and insulin. So it kind of just titrates those levels for us, that way we don't have too high of a level of either or. Pancreatitis. So pancreatitis is an inflammation of the pancreas, right? It's a sterile inflammatory process, though. It's not typically bacterial. And what happens here is that for some reason, and we'll talk about those reasons, those enzymes that the pancreas makes, they get released too early. And when they get released too early, and if they're activated, they can actually damage that pancreas and start breaking down the actual cells of the pancreas. So it starts to auto-digest, right? It starts to eat itself, if you will. If that thing continues to eat itself, then you worry it's going to cause inflammation, because we're starting to destroy that pancreas. It potentially is going to cause necrosis. We're going to start killing those cells of the pancreas, which is going to cause more issues with more enzymes being released, kind of perpetuating that cycle. Now, the most common causes of pancreatitis are gallstones and alcohol. Most common that you're going to see. Probably gallstones more so, but then definitely alcohol, especially if you're outside the military or in the military, depending on where you're at. What happens with gallstones is that you have a gallstone that's made in the gallbladder. It gets sent through that cystic duct. It makes it past that. It goes into that common bile duct, and when it gets there, it gets blocked. It blocks that pancreatic duct from actually releasing those enzymes. So when that gallstone gets in the common bile duct, we call that choledocholithiasis, right? There's a change in that name. When that gallstone gets stuck there, at the very end of that common bile duct, and that pancreatic duct can't release its enzymes, pressure is going to build up in that pancreas. And that pressure is going to activate those enzymes early. When those enzymes get activated early, they're going to start to go to work. They don't know where they're at. They just know, hey, I'm being activated. I'm going to start destroying or start breaking down things that I should break down. So fats, lipids, and carbs, right? Alcohol, that one's a little bit different. It can actually damage the pancreatic cells. This is more so like chronic alcohol intake, or if you drink too much alcohol in one sitting. If you have 1 or 2 glasses, it's not gonna cause this, right? But if you're a chronic alcohol user, or if you binge drink and you're drinking a lot that day for whatever reason, that can also cause premature activation of those pancreatic enzymes, which can start that process of breaking down the pancreas. What can also happen here is that at the very end of that common bile duct, it's called the ampulla of Vater, right? You guys remember that from AP1. There's this thing called the sphincter of Oddi, and that thing actually contracts and relaxes to help that juice from the pancreas go into the duodenum. Alcohol can actually cause that sphincter of Oddi to contract, and when that thing contracts, you kind of get that same process like the gallstone where you get that pressure buildup. That can also contribute to the early activation of those pancreatic enzymes. In a few slides from now, I threw in there just kind of what actually happens, because for me it kind of helps knowing like the details of why things happen. You don't necessarily need to know that. They're FYI slides. But the big thing you guys got to know is that really for the gallstones, it's that pressure buildup that can activate those enzymes. And for the alcohol itself can damage the pancreas, but also that pressure buildup also comes into play as well. Other things can cause pancreatitis. So if you have trauma to your pancreas, I think that makes sense. If you just, you get stabbed or you get shot in the pancreas, those are going to release enzymes. Certain medications can do it. A lot of blood pressure medications, like thiazides and Lasix, can sometimes do it. A lot of anti-HIV medications can potentially cause pancreatitis. And then triglycerides, very, very high levels of triglycerides can actually cause pancreatitis. And when I say very, very high, we're talking about like in the thousands. So if you have 1,000, 2,000 level of triglycerides, that can do it. Because if you remember, we talk about steatohepatitis, and we talk about how triglycerides, when there's too much, when they break down, you can make these toxic substances. With here, this is the same process. You make too many triglycerides, like you have a ton of triglycerides in your blood, your body tries to break it down, but you get this release of these toxic metabolites, if you will, that will go back to the pancreas and start causing damage that way. But the big thing is that if you have a patient who has pancreatitis and you think it's alcohol related, make sure you're checking for gallstones. Because if it is gallstones, if you don't fix that problem, you're not going to fix the pancreatitis. So even if you have a patient who is an alcoholic and you're like, oh, this is probably from their alcohol use, just do a quick ultrasound, very quick study to make sure that there's no gallstone kind of blocking that common bile duct. Very quick test to do. So here's kind of what happens with pancreatitis. So this is more related to the gallstones. So you got your gallstones in your gallbladder, right? It makes it past that cystic duct. It comes down to that common bile duct, and then it blocks this pancreatic duct and this inflow of water. And because we're blocking that, that pressure is going to build up, right? It's going to cause that early activation. When it activates, it's going to cause those enzymes to break down that pancreas. Now, if we have a gallstone stuck here, right? This thing is flowing. Is our patient going to have bilirubinemia? Are they going to have a high bilirubin level?
Where is it at?
It's right here in the cystic duct. No, right? Because you're still pushing that bowel out, right? So you're not going to get that obstructive jaundice that you would. But if it's here, would we have a high bilirubin level? Yeah. What if we had a big old tumor right here in the pancreas and it was pushing on that yeah, probably would, right? What if that tumor was over here? Not, because that bile's still flowing. So this is those FYI slides. If you want to kind of read them at your leisure, I think it just kind of helps put into perspective what actually is happening in the pancreas. But just more for information. Same thing with the alcohol. All right, so chronic pancreatitis. So with this is most commonly caused by alcohol abuse. So those people who drink tons of alcohol chronically every day, throughout their lives. What happens here is that alcohol causes this kind of low-level inflammation of the pancreas. It's causing that damage to the pancreas. And you're getting these kind of recurrent bouts of inflammation of the pancreas, but it's not to a level to where, because these patients, when they have this, they will have some epigastric discomfort, because that's where that pancreas is, right? It's right behind the abdomen. But, and maybe it's more, it's not as bad as, or you think about GERD, right? If you ever had GERD, you get that epigastric pain. Maybe it's a little bit like that, or maybe a little bit worse. But these patients are going to be used to it. They're going to be like, oh, I'm just having a bout of GERD right now. But what's happening is that pancreas is becoming inflamed. Those enzymes are being released, and it's causing a slow damage to those pancreatic cells. And what happens when we have too much inflammation, too much damage to a tissue? We start to develop fibrosis and scarring, right? Now with that scarring, what can happen is that we can start to destroy the texture, if you will, of the pancreas and the cells that actually are that we need in the pancreas. Typically, the acinar cells are damaged first, though. Why do you think that's the case? Why are those acinar cells that make the amylase and lipase and proteases, why are they damaged first before the beta cells? So they're the ones that make the enzymes, right? If that thing is kicking off these enzymes, and that those enzymes are damaging those acinar cells, then they're going to be damaged first. The beta cells are not part of the acinar cells, right? They do the endocrine portion of what we need for the pancreas to do. So they're not going to be damaged right off the bat. They will become damaged eventually, but those acinar cells are what are actually making the enzymes. So when we cause those enzymes to be active, they're going to start damaging those cells first. We start to lose those first. The beta cells will be damaged eventually, typically from that kind of secretion of those enzymes going towards those where those cells are made, but also to that fibrosis. That fibrosis is causing issues with the blood flow. So sometimes if that pancreas is scarring, we're going to cause decreased blood flow to those cells that make the insulin, the beta cells. So we may start to lose those later on, right? These guys are going to have, like I said, kind of this recurrent epigastric pain, often triggered by alcohol binges or alcohol use. sometimes if they're eating a fatty meal, because the pancreas's job is to release lipase to help break down fat. So if they're eating a fatty meal, that can sometimes trigger it. Nausea and vomiting with pancreatitis, that's a very, very common symptom. And we'll talk about more of that here in a second. They may have weight loss because if we're not making these enzymes that we need because they're being damaged, when we're passing food to our small bowel, we don't have the amount that we usually need to break down those fats that we need for different parts of our cell metabolism. And so guess what? Our body's going to say, okay, we need energy. We're not getting energy really from what we're eating because we can't break down those fats. So we're going to start pulling fat from our fat cells because those fats or triglycerides, which we can use for energy as well. So they're going to start losing weight. The amylase and lipase level, they'll be mildly elevated. Why do you think that's the case? So they're going to be mildly elevated because we're destroying those cells that make them, right? So if we destroy them, they'll be higher, they'll be in our blood, but over time, as we keep destroying them, those levels are going to be not as high as they should be because we've destroyed those cells that make them. Potentially, they could even be normal if it's really, really bad. But if we destroy those cells that make the amylase and lipase, when they're released into our blood over time, we're going to start, that level's going to start to decline because we don't make them as we used to. As our cells are destroyed. If you do an abdominal CT, you may see pseudocysts. We'll talk about those here in a second. And you may see calcifications in the pancreas. Again, if you remember dystrophic calcifications, if tissues start to die, they start to kind of latch on to calcium. And so as a result, if you see calcifications in any organ, that's an indication that that organ's been damaged, that tissue's been damaged for whatever reason. So acute pancreatitis. This one, this is typically very intense epigastric pain. So it's pain in the epigastric still, but more intense than the chronic. It's typically described as a boring quality. When I say boring, if you think about like, what do you guys think boring means? Like drilling a hole, right? Like a deep, very, very intense burning pain, like you're digging into something. And because of where that pancreas sits, it's retroperitoneal, it's behind that stomach, that patient may feel it in the back as well. It's worse when they're lying supine, because think about it, when that pancreas is inflamed, you lay down, it's being compressed against that aorta on the back side of it, and then you got the stomach compressing it as well. So these patients are going to be very uncomfortable when they're laying supine, when they're laying on their back. When they sit up, when they bend forward, you're taking some of that pressure off. You're taking that pressure off from the stomach off of the pancreas. It's going to help kind of relieve that pain a little bit. Nausea and vomiting again. They may have trouble, not trouble breathing, but just breathing a little bit different, shallow respirations and mild tachypnea. So that pancreas sits up here, and right above that is the diaphragm. So every time you take a deep breath in, you're compressing that pancreas as well. And so these patients are going to take very kind of shallow, quick breaths to try to get their oxygen in, but every time they breathe, it's going to hurt. So they're going to take these very shallow breaths. So I told you that the pancreas is retroperitoneal, right? But right in front of it is the peritoneum. So right in front of it, because you got that stomach right in front of it, and that peritoneum is right in front of it. If those enzymes start to irritate that peritoneum in front of it, then we can start to cause a peritonitis, which can lead to a paralytic ileus. Because if that peritoneum is inflamed, that can shut down our intestines, and our intestines are like, hey, I'm going to stop working. And so you go listen to their bowel sounds, and they're very, very, quiet or absent potentially. If you do an abdominal X-ray on them because you're not quite sure what's going on, you may see that air kind of coming up from that you can see on the X-ray. So it may lead to an ileus potentially. And very, very severe. So this is kind of worst case scenario. So necrotizing pancreatitis is just kind of the worst kind of pancreatitis, and what that means is that those cells are dying, and then as they're dying, you start to get these hemorrhages, this bleeding of the pancreas. When that happens, that bleeding can sometimes travel from because it's right there behind in the back of the stomach, right? But right above it is that liver, and that liver, if you recall from A&P, has that falciform ligament. That falciform ligament attaches to the anterior abdomen, and so if it's bleeding, it can actually go up into that falciform ligament and then kind of transfuse or diffuse down to the anterior abdominal wall. If that happens, you'll see a colon sign. And what that means is that you have ecchymosis or bruising around your umbilicus, around your belly button region. If you see that, that's a very, very bad sign. That's a sign that you have kind of the worst type of pancreatitis. And typically we're going to admit these folks and do a lot of stuff to them. Now, if it doesn't go that way, because it sits retroperitoneal, so it sits behind the stomach, you may see what's called a Gray Turner sign, where you get this ecchymosis in the flanks. So where those kind of sides over here, kind of where the kidneys are at, but that pancreas is right back there. So if it bleeds and it goes posteriorly, you can see that bleeding at what we call it a Gray Turner sign. One way to kind of remember this is that you have to turn right to look at your flank. So that's one way to kind of suck into. When you check labs on these patients, they'll have a very, very high lipase level, and that's 3 times greater than the upper limit of normal. That's classic for diagnosing pancreatitis, that lipase level. Amylase will also be elevated, but that lipase will be, the lipase is more specific for the pancreas. If you make amylase in other tissues as well, like your salivary glands, your parotid glands, you'll make amylases there too. Lipase is just specific for the pancreas. You may see an elevated trypsin level. So trypsin is one of those proteases that the pancreas makes. We don't often get this in real life. You may be able to get it at whatever lab or whatever MTF you work at, but it's not one of those typical things we get. It's more specific for the pancreas, but if you were to order it, you probably have to ship it out and then get it back a few days later, which we need to figure out what's going on now, so we don't typically get that one. And like I told you guys, you want to get that ultrasound to make sure that there's no gallstone blocking that common bile duct, because if it is, we can treat that. We can get that gallstone out of there and then get this patient better. If we miss that, if we don't do the ultrasound and we don't check, then we may assume it's an alcoholic pancreatitis, and then we're not treating the patient because that gallstone is still blocking that pancreatic duct. There's an example of the colon sign, so that ecchymosis around the umbilicus and the Turner. So this is not just specific for pancreatitis. This can really happen with any type of intra-abdominal bleeding, but we associate it more so with pancreatitis. So how do we treat these guys? So if they're mild or uncomplicated patients, which are going to be most of your patients that are going to be out there that you're going to see, we give them fluids, right? Now, why do we give them fluids? They're throwing up, right? They're probably not drinking because they feel sick, they're nauseous. And on top of that, you have inflammation going on. If you have a lot of inflammation, what could potentially happen? Get that third spacing, right? If you get third spacing where you get this fluid in the interstitial space, that fluid is no longer in your blood vessels, starting to go in the spaces that it shouldn't go. And so these patients are going to start to become very, very dehydrated. So they're throwing up, they got third spacing, so we want to give them fluids to get their fluid back into their blood vessels to make sure that they don't develop that hypotonic or the hypovolemic shock. We're going to treat their pain. We'll give them morphine or maybe Dilaudid or something just to kind of get their pain under control depending on the severity. Sometimes you can get ketorolac. Treat their nausea. This depends on what you have, metoclopramide or maybe Zofran depending on the severity. And then we're going to give their pancreas time to rest. So we want their pancreas not to work. We want it to stop secreting enzymes. So obviously we're not going to give them alcohol. Don't want to give them alcohol while they're having a pancreatitis attack. We'll keep them NPO, which just means that nothing by mouth, right? That's what NPO means. You don't want to give them anything. Over time, you can start giving them clear fluids. You can give them, Jello. You can give them water, maybe something that's not going to kick off their pancreas to release enzymes. But we don't treat this with antibiotics because remember, it's a sterile process. There's no bacteria causing this inflammation. If we're able to get their pain under control, and then we're able to make sure that they're drinking water and they're doing fine, they're not vomiting, we can discharge them, and then they're going to come back and see you the next day or so, right? And you're just going to make sure that they're still doing well, that their pain's under control, that they're able to keep their fluids in. If they're still vomiting, so you have this patient, this is typically happening in the ER, by the way. If you have a patient with pancreatitis in your clinic, and you're not working in the ER, get them to the ER, because you don't have time to do this. But if this patient is still vomiting, right, you've treated their pain, you've given them antiemetics, you're giving them fluids to drink, but they keep throwing this up, we can't discharge them home. Or if their pain is still uncontrolled, we can't discharge them home. We're going to admit these folks. So if somebody is still throwing up after 5-6 hours, you need to admit them. Probably admit them a lot sooner, but you just can't send them home, okay? If it's more severe, right, if they have that colon sign, that Gray Turner sign, they have signs of hemorrhage, we're going to admit them. If they have peritonitis, we're going to admit them because we don't want this to get worse. If they develop an abscess, which can sometimes happen, especially if that inflammation is causing a lot of issues with that small bowel, sometimes that bacteria can get into the pancreas. And you get to those cysts I'll talk about here in a second, then we're going to admit them. If they have significant comorbidities, so say somebody has heart failure, and they already have problems with fluid overload, and we need to treat them with fluids, we're going to admit them. We got to make sure that we're not overly hydrating them. If they have some type of autoimmune disease or they're taking medications that lower their immune system, they're more prone to infections. So we're going to admit them. We're not just going to send them home. So it really depends on your patient and kind of what else is going on as far as comorbidities go. So complications. So obviously peritonitis, we talked about that. If those enzymes start to leak into that peritoneum that sits in front of the pancreas, then you worry about that peritonitis and worry about that severe inflammation, which can cause ascites. So very, very bad if that happens. These pseudocysts. So pseudocysts means false cysts, right? They're still cysts, but what happens here is that when that pancreas is inflamed, it's sending out its enzymes. There can be fluid that can kind of form around the pancreas. So when that happens, what the pancreas tries to do is that it starts causing fibrosis, right, scarring, which keeps that fluid kind of intact, right? So it's still a cyst, it's just not lined by typical epithelial cells. It's lined by fibrous tissue. So that's why they call it a false cyst or a pseudocyst. You worry about these cysts though because if they get too big, they can sometimes push on other parts of the organs in our GI tract, like our stomach, which can cause other issues. Or sometimes those cysts can have blood in them, or they can erode into a blood vessel, and then if those things pop, the patient can bleed out. Hyperglycemia, diabetes, I think that makes sense. If you start to have an inflamed pancreas, you're going to start to damage those beta cells, which are going to impact our insulin production, so this can happen after the fact. Those calcifications, we talked about that. Really with these calcifications, what you worry about is not only, it's a sign that there's damage to the pancreas, but sometimes these calcifications can block that pancreatic duct, and when that happens, it can increase that pressure as that fluid is trying to escape the pancreas. So sometimes that can be more predisposing to developing more pancreatitis. Then abscesses, like I talked about, if you have some type of dead area and those intestinal bacteria get to the pancreas, it can sometimes cause an abscess, or that bacteria can get to one of those cysts and cause an abscess as well. All right, so diabetes. So we'll talk about type 1 and type 2. Diabetes-wise, in general, this is what's supposed to happen, right? So our pancreas has these beta cells. These beta cells, they secrete insulin, and then what happens is we eat something, our blood sugar goes up. That insulin goes to cells that are responsive to insulin. So typically these are fat cells, these are muscle cells, it's in the liver as well. And that insulin goes to these receptors on those cells. And what that receptor does is it sends a signal to that cell to get these glucose transporters to go to the cell membrane. So it sends a signal to the cell. This complex process kind of happens, but it calls these glucose transporters to go to the cell membrane. And when it gets to the cell membrane, that's what actually lets the sugar into the cell. So the insulin is kind of like the first step. It activates the insulin receptor, and the signal process happens, and then these glucose transporters merge into the cell membrane, and then that lets the sugar in. In diabetics, we have a problem with this. We have a problem where the insulin is not working well, or we're not making enough, and so as a result, we get this high blood sugar level, which causes a lot of issues later on down the line. If we're not making enough insulin, or if the insulin gets to the cell and then that signaling process doesn't take place to get those glucose transporters to the cell membrane, then we're going to have a high level of sugar in our blood. There's two types of diabetes, type 1 and type 2. Type 1 used to be called insulin-dependent or juvenile diabetes. They've gone away from that. You still may hear people talk like that, and get referred that way, and they're not wrong, but we don't call it that anymore. We just call it type 1 diabetes. Because the problem is that adults can have type 1, right? It's very common for adults to have type 1 or develop it as an adult. They're still insulin dependent, but adults can get it as well. In type 2, they used to call these non-insulin dependent or adult onset. But the problem with this is that type 2 is now, or has been occurring in kids for a while now. So children can have type 2 diabetes. We don't say non-insulin dependent because initially, when somebody's first diagnosed with diabetes, typically type 2, you can treat them with other medications besides insulin. As that diabetes is not controlled, then you worry about needing to go to insulin, but that's kind of a later thing. Type 1 diabetes. So most of the time, though, it's going to happen in the early ages, typically less than 30, most of the time between 8 and 12, but it can occur at any age. It doesn't necessarily have to be 8 to 12 years old. What happens here is that we have an autoimmune destruction of our beta cells. So our body is starting to destroy our beta cells. When that happens, those beta cells are no longer making insulin like they're supposed to. But the thing with this is that, when a patient comes to see you and you think they have type 1 diabetes, it didn't just happen overnight. This is a long process. And I got this diagram here, this table. It's a hypothetical kind of what could happen because, like I said, it can occur at any age. But you have some type of genetic predisposition, right? Some type of inciting event. It could be some type of sickness, some type of virus. We don't know, right? Something kicks this thing off. Our body starts making these antibodies against the beta cells and the insulin. And then over time, as it starts to destroy those beta cells, this patient is starting to, their blood sugar is starting to slowly increase, right? To that point to where all of a sudden it appears that they have diabetes, but this was a long process. It started years and years beforehand. When you run labs on these patients, when you're checking a patient for diabetes type 1, you're going to run a fasting glucose, so they're not going to eat for 8 to 12 hours. You'll draw their blood. You'll see how high that is. So they'll have an elevated fasting glucose. They'll have an elevated hemoglobin A1C. Have you guys talked about that in lab yet? No. Hemoglobin A1C is a very, very good test. It's a 3-month look, essentially, at the patient's blood sugar. What happens with hemoglobin A1C is that your hemoglobin, the hemoglobin that we normally make, hemoglobin A, if it's exposed to glucose, especially high levels, that glucose can actually attach to the hemoglobin. And once it attaches, it's not letting go. Then we're able to draw that patient's blood and see how much hemoglobin from this patient has this sugar attached to it. And they typically result that as a percentage. So if they have 6.5% of their hemoglobin has sugar attached to it, then that's the cutoff for diabetes. If they have 5.6%, well, that's kind of right there, but that's still normal. And then 5.7 to 6.4 is kind of that pre-diabetic range. So they're not diabetic, but they're about to get there. If you can see islet cell antibodies. So these islet cells, that's where those beta cells sit. So you can run a test, you can see the antibodies against them. They'll have a decreased insulin level because we're destroying the beta cells. And so when we draw their blood, we draw their insulin level, it's going to be low. So we call this absolute insulin deficiency because we're destroying those beta cells. They're not coming back, so they're not going to be making insulin. And the only way we can treat these guys is to treat them with insulin. We can't give them any other medications. Insulin is what they need, so we're going to give that to them exogenously. There's different kinds of insulin that pharmacy will get into, but we're going to give these guys insulin. So type 2, this is far more common that you're going to run into. So with this one, our patients are insulin resistant. So the beta cells are still making insulin, but the tissues, those tissues that need that insulin to kick off that process to get those glucose transporters to the cell membrane, they're not responding like they're supposed to. Obesity and sedentary lifestyle are the 2 most common causes. Obesity, so the fat cells actually release these inflammatory mediators that interrupt that process of calling in those glucose transporters to come to the cell membrane. So insulin comes, it's attaching to the insulin receptor, but the fat that we have, right, especially if you have too much of it, impacts that calling of those glucose transporters so they never come to the cell membrane. So order to call them, you need to keep making more and more insulin kind of to increase that signal to try to get them to start working. Sedentary lifestyle, so exercise is super important. So exercise actually, I don't know if you guys have, well, exercise is, it can actually call those glucose transporters to the cell membrane without insulin. That's why we tell our patients we want you to exercise, because it can call those glucose transporters without insulin at all. But if you're not exercising, you're not calling those glucose transporters to the cell membrane to get that sugar in, over time your body's going to stop, those cells are going to kind of forget how to work, right? And so when insulin comes to trigger that process to get those transporters to the cell membrane, because you're not using them, because with exercise you don't need it, the longer you don't use it, the harder it is for that cell to kind of know what to do, call those transporters. And so these people are not exercising. If you don't use that process, if you don't use that transporting cycle, they're not going to respond to insulin like a normal person should. Genetics play a big role as well. Genetics play a big role. That's why we ask our patients their family history, because if there's a family history of diabetes, chances are they're at increased risk, and that's due to kind of a number of issues. The thing with this though is that they're going to have relative insulin deficiency. So they're going to still make insulin. The beta cells are still making the insulin, but because those tissues are not being receptive to it, they're not responding to it, your beta cells are going to start ramping up. They're going to start making more insulin to try to get that signal to that cell to get those transporters to the cell membrane. But your beta cells can only do so much. They can only do that for so long before they start to break down and burn out. So once they burn out, then we have a decrease in insulin production. So we had this initial high production, trying to get that signal across. This is years though. This is the kind of years of kind of ongoing insulin production trying to be made. After a while, they're like, we're done, we can't make any more, we're damaged, and so they stop making insulin. So that's when these patients, especially later on, need that insulin later on down the line. When you run blood tests, same thing, they're going to have elevated fasting glucose, a high A1C. They're not going to have any antibodies. This is not an autoimmune issue, right? This is just from dietary habits and lack of exercise. Maybe genetics as well play a big role. Their serum insulin initially is going to be high, because those beta cells are kind of going into gear to get that insulin production going. You may catch it at a time to where once it starts declining, it may be normal depending on where you catch it, right? Because if they've had this going on for 5 years or 10 years and those beta cells are burning out, and you run and check their insulin level, it's already on the decline. But because you caught it at a time where it's declining, but it's still within the normal limits, it may be normal. What's going to happen though is that insulin level is going to start declining to below normal, right? As these beta cells start to burn out more, that's going to cause these things to, your insulin level is going to be a lot lower than normal. How do we treat this? We try to get them to lose weight. We try to eat a lower sugar diet, exercise. We can give them medications. There's tons of medications we can give these folks that you'll learn in pharmacy. And then if it's later on and we need to give them insulin because those beta cells are not working well and all the medications that we can give orally are not working well for this patient, then we may have to revert to insulin towards the end of the line. So this is just a table just to kind of let you juxtapose these different types of type 1, type 2. Might be beneficial if you are studying this. All right, so 3 polys. So this is very common with both type 1 and type 2. This is how your patient's going to present initially. They're going to have polyuria. So the higher blood sugar you have, you can only hold so much in your blood, right? Once it gets to a certain level in your blood, we're going to start to pee out that blood sugar, or that glucose. When we urinate glucose, what does water like to do? It likes to go with the higher concentration, right? So when we're peeing out all this glucose, that water that's in the fluid that's in our blood vessels, as it's going through that kidney, is going to go with the glucose. These patients are going to have polyuria. They're going to be peeing a lot more because they're peeing out glucose, and that water's going to come with it. They're going to have polydipsia because they're peeing a lot. So they're losing all their fluids or losing a lot of their fluids. So then these patients are going to respond by trying to drink more water. But the problem is that they're not going to feel like it quenches their thirst. They're going to because they're peeing so much glucose and that water's falling with it. When they drink water, it's not going to help them. They're going to still feel thirsty, so they're going to be drinking a lot of water. With polyphagia, this means that they're eating a lot more. So if we're not letting glucose into the cell, we're not making that energy. We're essentially starving that cell. And then our body says, we need more energy. Keep eating, keep eating. They have enough glucose, but this glucose is not getting in the cell. So they're starved, and so the patient's going to feel starved, and they're going to eat more. They're going to feel fatigued. I think that makes sense. If we're not making energy because we're not getting glucose in the cell, they're going to feel tired. And then the weight loss, right? If we can't use glucose for energy, what are we going to revert to? Our fats. And so our fats start to break down, and then we start to lose weight from that. The labs. So that fasting glucose. So this is a very good number to know just in life. If the fasting glucose is above 126, when you draw this patient's blood, that's the cutoff for diagnosing diabetes. But the thing with that is that you need more than once. You need to repeat this the next day or maybe a few days later just to confirm that this is diabetes. A fasting glucose of 100 to 125 is pre-diabetes, so they're not diabetic, but they're on their way of becoming diabetic. So we definitely need to step in when they're pre-diabetic, make sure they don't progress to diabetes. Once you have diabetes, you've had diabetes. If we get it under control, if we can lower that blood sugar, perfect. That's what we want to do. But you're still a diabetic. It doesn't go away. The other test is that hemoglobin A1C. So I told you 6.5 is the cutoff for diabetes. This is why, do you guys know why they looked at their blood sugar for 3 months? What do you guys think? Right. Life of a red blood cell is about 3 months, right? And so that's why it's a 3-month check. We need to see, because we want to see how that blood sugar was when that blood cell first came on board to when it died. And so this is a 3-month look at their blood sugar. These other ones over here, this just kind of tells you what's normal, what's pre-diabetic, and what's diabetic. From 126 or greater is diabetes, and then A1C at 6.5 is diabetes. So this slide right here is a very, very good slide to know. It's a very good slide to know. When you have diabetes, it's going to cause other issues besides high blood sugar, right? This is what we're trying to avoid. It's going to damage the blood vessels, especially the small ones of our eyes, our kidneys, and then also the blood vessels that supply our nerves. With diabetes, it's going to increase your risk of atherosclerosis. So if we're using more triglycerides, more fats as energy, because we can't use that glucose, those triglycerides are going to be released from the fat cells. They're going to go into our blood, and that liver is going to take up those fat cells, or those fatty acids that triglycerides are made of. When the liver is making LDL, part of that LDL, that low density lipoprotein that can cause atherosclerosis, part of that LDL is composed of these free fatty acids, these triglycerides. And so we're going to be making more LDL, which is going to then go to the endothelial wall of our blood vessels and start causing those plaques. So they're at increased risk for plaque development. High glucose can damage blood vessels. There's several different ways how this happens, but big thing is that high glucose damages blood vessels. When those blood vessels are damaged, especially in the kidneys, it can start to cause scarring of the kidneys. We call that glomerulosclerosis. When those kidneys are scarred, they're not filtering like they're supposed to. And so we get a decrease in their kidney function, their filtration rate, their GFR, is what we call that, glomerular filtration rate. If we have a decreasing kidney function, we're going to have an increase of waste products because those kidneys are scarred up, they're not getting rid of that waste, and so then that can cause other issues. Potentially, they'll need dialysis later on if we really damage their kidneys. The eyes, so behind our eyes we have our retinal capillaries. They're what help us see, right? They help supply the cells of our eyes that help us see. If we cause damage to those small capillaries, we can cause microinfarctions, we can cause hemorrhages, we cause ischemia. What happens is that the eye tries to make more blood vessels, but these blood vessels are very, very weak. And these blood vessels can actually grow into the vitreous of our eye, so that kind of jelly-like substance in the back of our eye. When those blood vessels grow into the vitreous, and that vitreous contracts, which normally it does it as we live life, it just starts to kind of get smaller and contract. It can pull on those blood vessels that are attached to the retina, kind of rip that retina off. So it causes retinal detachment, it causes blindness. So This is one of those other things we worry about when somebody's diabetic. They typically get their eyes checked annually. If that blood sugar is too high, it can go into the lens of their eye. And when that happens, that can cause swelling and cause blurred vision. The peripheral neuropathy, this is pretty common, especially in your uncontrolled diabetics. So if you have damage to the blood vessels that supply our nerves, we start to destroy our nerves, start to cause issues with numbness and tingling. The sugar can actually get into the nerve as well and cause swelling of the nerve and potentially cause it to rupture. So that can damage the nerve as well. Most of the time, it's going to start in your hands and your feet. What's called a stocking and glove neuropathy. So hands and feet are typically the first signs that somebody has peripheral neuropathy. And then obviously, if you have high blood sugar in your blood, then bacteria love sugar, so you're just at greater risk of having harder to treat infections. So just a kind of picture of all the issues that can happen with uncontrolled diabetes. All right, let's take a 10-minute break.
Come join the
Medical,
logging.
baby.
Join that logging world, baby.
Damn. What am I on? I think I'm on the lowest one.
That was the plan for the I know. I never went. But this one went at 6 a.m. because going at 7 is supposed to be like brunch, and then like a whole half week. So it went at 6. By itself, it's all done. Got the cake done. Hospice in my house. Why did they bring it on Thursday? Pick up the cake. And then I'm trying to Is it far? Oh, okay. Oh, that's cool.
Which one?
That's passing. That's a 60. The run is probably like 21 minutes.
First one I did on Friday, that was like 30 slides.
It is only 3 reps too.
It was like my head. I continued on Saturday and I did. Took some more.
Three continuous, so you can't free it. They literally say, I'm pretty sure. Yeah, you pick up the wrapper. Yeah, yeah, so pick it up, and then pick it up, and then that's not the same. That's what I'm saying. I thought it was like a weird, yeah, it's next part. And then after the carry, and then another sprint, another lap. Why are we then you do the plank, and then you do but the run passes like 21 minutes.
But it's followed by.
Right at the end there. Yeah, that last sprint, I always feel I don't think we'll make 460 this go around for the exception. I'm still going to try. Oh,
Yeah.
I'm gonna
I just wanted to see the different parts. I don't pass that one.
Yeah.
I think we still have to do the 140.
Ball throw was
They said it was like you're on it.
try to get it.
That's true, but we also missed like teammates because of the commercial days and so they're probably gonna make it probably gonna stay and miss one. So they say
Yeah, you want to get like a wide. My ability to recall information about them is pretty non-existent.
no worries.
HTFT apparently based on yeah, like that wasn't going to be. That's it.
Well, it just means that if you're in a sports one, like
That would be the case. All things we can go back and forth. You can also go back and forth. Alright guys, we're almost done. Two more classes and then review and that's good. Alright, so pancreatic neoplasms, right? These are very, very serious, very dangerous. Because once somebody has pancreatic cancer, adenocarcinoma, pretty much a death sentence. Typically, these folks are going to be a lot older. Most of the time, it's going to be your smokers, but it may not. But smoking is very puts you at high risk for developing this. The problem with pancreatic cancer is that once you develop it, it quickly metastasizes, and most of these people die typically within the year. Hopefully 2 years if you can buy them time and treat them with chemo and maybe surgery depending on how severe it is. But these people are going to pretty much die within 5 years for sure. Very, very rare that somebody can actually live through pancreatic cancer. There's a lot of lymph nodes around the pancreas, and so this thing likes to spread quickly. It likes to metastasize. It's the third leading cause of cancer-related death in the world. It's anticipated that, I think, by 2030 it's going to be the second leading cause, but it's one of those things that, again, if you catch it, it's pretty much pretty bad. The problem with pancreatic cancer is that your patients may have it and not present any symptoms, right? They may potentially have weight loss depending on how long they are. They may have decreased appetite, especially if that pancreas is pushing on the stomach. They may have nausea and vomiting. Well, when I've seen it, these patients, and I'll tell you about one case here in a sec, these patients were asymptomatic. So they may have no symptoms or very kind of generalized mild symptoms. It all depends on where that pancreatic tumor is. Like we talked about, most of the time, 60% of the time, it's going to occur in the pancreatic head, which is good. Which is good because that gives us it helps us identify it quicker. When it happens in the pancreatic head, it's going to obstruct that common bile duct. When that happens, you're going to see that hyperbilirubinemia. So that gives us it's still not good that they have it, but it just makes us be able to identify a lot easier, a lot sooner than if it was in the pancreatic tail. When you do weight loss, I think, if you think about cancer, weight loss is one of those things that you got to consider. New onset diabetes. So if there's cancer in the pancreas and it starts to locally invade first, right, that local invasion that can happen with carcinomas, it can start to destroy those beta cells that make the insulin. So your patient may potentially present with new onset diabetes. So they were fine 5 months ago, come see you, you draw their blood for a reason, now they're diabetic out of nowhere. That should raise that flag, like, oh, what's going on? That's not typical. Typically, it's like kind of a slow progress, especially if it's type 2. And all of a sudden they have diabetes when they were healthy otherwise. That should kind of raise that red flag that maybe there's a type of pancreatic tumor going on. They may have pain in the epigastric region. It just depends on how big that thing is, but typically it's going to be that painless jaundice. So I had a dude one time, probably my second year of being a PA. It was on my first base for sure. And he was a kind of an old timer, retired, Air Force dude, kind of grumpy, but he smoked, he drank, his diet was crap. I think he was pre-diabetic, but his cholesterol was really high, right? So I talked to this dude and I'm like, hey, I'm a brand new PA, I'm still kind of brand new, 2 years out, you're still kind of brand new. Trying to connect with him because his lifestyle was bad, hypertension, all that kind of stuff. So he was one of these dudes who didn't like to take medicine. He hated taking medicine, didn't like coming to get care. But I think what was going on with him is he was getting older. He was starting to kind of see like, I'm not going to live forever, so I got to take care of myself. So I talked him into starting him on a statin, medication to lower his cholesterol. He didn't want to do it at first, but I explained like the risk benefits and all that stuff, and told him his risk of not doing it, and he finally agreed to start the statin. So if you'll learn when you learn this in pharmacy, with statins, sometimes they can damage the liver. So you gotta make sure you're checking their liver enzymes when you start them on medication, just to make sure it's not causing too much issue. So I drew his blood. So he started the statin. Told him to repeat labs in 2 months, and then he didn't come see me. He just repeated the labs. I got the labs back, and I pull up the labs, and I'm like, what the hell? Because his total bilirubin was like sky high. He had some other abnormalities on his liver enzymes and some other stuff going on. But I was like, oh shit, what did I do? What did I do, right? Because he told me, he was like, I don't want to start this because I'm afraid what's going to happen to my when I start this medication. And I saw his bilirubin was super high, and I'm like, oh crap, like, that shouldn't happen with this. What happened? So I called him on the phone, and I'm like, hey, whatever your name is, and how you doing? And he goes, why? He knew he escaped blood, right? And I'm like, oh, well, your labs are a little abnormal. He goes, what did you do to me? And I'm like, I don't know. So I told him, I was like, are you feeling okay? Like, your bilirubin is really high. And I explained. He goes, is that why I'm yellow? And I'm like, this was 2 months. I'm serious. This was like 2 months of him being on this medication. And I'm like, I don't know if it's from, I didn't know, I hadn't seen it or learned that statins could do this, right? Didn't know this. It doesn't, by the way. But I was like, I don't know, sir, but I think your bilirubin is so high, and I forget how high it was, but it was very, very high. I was like, you need to go to the ER because I don't know what's going on with you, and you're telling me you're jaundiced, and so we need to figure out why. He didn't want to go to the ER, so I said, okay. So I went to talk to the doctor that I worked with. I'm like, telling him what's going on. He says, this looks like maybe has some type of blockage going on. I said, okay. So I called. It was a small MTF, so we didn't have CT. So I called the hospital that was in town, and I was like, hey, can we get this guy in to get a CT like today or tomorrow? And they're like, oh yeah, sure. They worked him in, did a CT, and this dude had a tumor in his pancreas. So he had obstructive jaundice from a tumor in his pancreas, not from the statin. So then, you don't want to talk about that over the phone, right? And you see this mass in the tumor, and you know it's cancer, but he doesn't know it's cancer. So I call him in, and I'm like, he sits down, he's jaundiced, like he's really jaundiced. And I said, hey sir, you got this mass in your tumor. We don't know what it is quite yet. We need to make sure we get a biopsy, kind of see what's going on. I said it potentially could be cancer or may not. I knew it was cancer, but I didn't want to scare him. And so I called GI again in town, and then they got him in pretty quickly and biopsied his pancreatic cancer. So during that time, this dude was normal. I mean, he had health issues. He was fine. 2 months later, he had this mass for a while, right? He wasn't showing any symptoms of it. And then during that time, when I was repeating labs, his bilirubin, his common bile ducts became obstructed from the tumor, and he developed that jaundice, which helped us catch that pancreatic cancer. He ended up dying a couple years later, but yeah, it was sad. All right, enough of that. So pancreatic. So if the tumor is in the body of the tail, you're not going to have that obstructive jaundice like you would with the head. So that's why if it's in the head, you can find it quicker. If it's in the body of the tail, it's a lot harder to find, which means that they're going to metastasize. They'll metastasize way. You're not going to catch it in time, essentially. So they're going to metastasize and eventually pass from that. But it doesn't cause jaundice. And that's what that can look like. You got that tumor in the head of the pancreas, and then it obstructs that common bile duct. And these guys here, they're twins. So one dude has, obviously, jaundice, the other guy doesn't. And these last kind of tumors, these are called islet cell tumors. These are far more rare. And the good thing about them is that they cause symptoms a lot sooner, right? So we're able to catch these a lot sooner and treat them because they're going to be messing with the endocrine function of our pancreas. So the first type is insulinomas. These are beta cell tumors, so tumors of the beta cells. When this happens, you can get this kind of massive increase in insulin production, and that's going to cause these patients to become hypoglycemic. They're going to have a low blood sugar, so they're going to be, passing out of nowhere. Their sympathetic system is going to kind of run into gear when they don't have enough blood sugar, so they're going to have sweating. They're going to have jittery. They're going to feel jittery. We're going to work this up. We're going to find that they have a high insulin level because they're just kind of fainting because their blood sugar is too low. And then we'll treat them with IV glucose and then take out that tumor, and they're typically going to be fine. This gastrinoma, another type of tumor of the islet cell. With this, there's too much gastrin being produced, right? Now, typically, gastrin is not produced in the pancreas. Gastrin is produced in the stomach. The stomach has certain cells called G cells, which make gastrin, which tell our parietal cells, which make the acid, to make acid, right? With this guy, there are these tumors in the pancreas that revert back to kind of their old ways, their fetal ways, and they start making this gastrin, which they shouldn't. They shouldn't make it at all. So with these folks, they're going to have an increased gastrin level, which is going to cause their parietal cells to make more acid. And these folks are going to have these kind of very, very high, hard-to-treat gastritis or acid reflux. They're going to have these peptic ulcers because they may come in and we think it's just GERD. We treat them with PPI, but that's not going to cut it because they're making so much gastrin. This is called Zollinger-Ellison syndrome. And this is just these folks, they have these ulcers. We treat them with PPI. We can't get it under control. So send them to GI, and the GI will take a biopsy and discover there's a way to kind of get into the pancreas through the duodenum. We'll take a biopsy and see that these are tumors of those cells, and then they'll take them out. And then once they do, the patient's better. All right, that was it for that. Questions about pancreas? All right. Let me just do the quick. Got some time here. I'm a crier, by the way. I cry a lot, so sorry, but got a little emotional. All right. All right, so going back to the liver that we finished last block, what do you guys think for this one? All the above. All right, how about this one? What do y'all think?
D.
B? Think it's D? So one way to remember that blood causes diseases, B, C, and D. Those A and E are going to be your fecal oral route, remember? With the E, you worry about that fulminant hepatitis, right? Get pregnant ladies. What do y'all think? B? So B and C, you worry about that chronic cirrhosis, which can predispose you to developing liver carcinoma. Can D do it? Hepatitis D? It can, but it has to do it with hepatitis B, right? D is dependent. do y'all think? C? Maybe? Maybe B? Maybe?
All the above.
The cholesterol zones, I know your slides say yellow and brown for cholesterol, so I wouldn't do something like this on the test, but, those black, what are the black associated with? From what's gonna happen to them? What is it mostly composed of? The black ones. Bilirubin, right? Black are the bilirubin, too much bilirubin. The brown stones, not talking about the yellow brown stones, just the brown stones. So they're weird ones, liver, flukes, right?
Yeah.
And then what are the 4 F's? Do you guys remember?
40, female, fat, and fertile.
Yep. So fat, 40, fertile, female. That's
Let's
most
get
of
the
the
female fertile part, but.
C, right? So we didn't talk about diabetes insipidus, not yet. We will. Essential diabetes, we didn't talk about that. Sedentary diabetes, that's not a thing. You can get diabetes from being sedentary. But type 1 is that absolute, we're destroying those beta cells, so we're not going to make insulin, versus the type 2 is relative. We still make insulin, and we're going to have that increased production, but over time it's going to start, you're going to start to burn out, we're not going to make insulin. You guys remember this?
Pre-diabetes is C. Pre-diabetes.
Pre-diabetes. So they're not diabetic, but they're on their way to becoming diabetic, and so we make sure we step in and we kind of make sure our patient's aware that you're on your way to becoming diabetic. If you don't change your lifestyle now, you'll be a diabetic, and then all those complications that we kind of briefly talked about, you have those risks of going blind, you're having increased risk of heart attack, stroke, kidney damage, nerve damage. So we try to get them when they're at this level. Try to get them before this, right? But if they're at this level, then we have to step in and make sure that they're aware. If they don't change their lifestyle, it's going to happen. Just talking about this.
So.
So we're making this gastrin, shouldn't make it, have these peptic ulcers that just aren't getting better, despite what we're doing. So we go in, see that they have this tumor, remove it, patient's better. All right. Good job, guys. So so I'm working with the class leader. He's going to keep me updated, but we'll do a review. Day is pending, but we'll figure it out, and then make sure you guys are good to go for the test. I know the next one is pharmacy, so I know you guys are worried about, rightfully concerned about that one. But we'll do a review and make sure you guys are good to go for our test. And if you guys have any questions from now until then, let me know. I won't be here next Tuesday, and then I'll be here